Welcome to the deep dive. Today we're talking about something, well, fundamental. Breathing. Seems simple, doesn't it?
Inhale, exhale. Yeah, sounds easy.
But it's not. The respiratory system is incredibly complex, surprisingly vulnerable too, especially, at the very start and end of life.
Yeah.
We've gathered a whole stack of sources, medical notes, clinical info, looking at some really critical respiratory conditions, from issues affecting the tiniest newborns right through to chronic challenges adults face. Big stuff.
Absolutely. And our goal today really is to cut through all the jargon. We want you to be able to tell these conditions apart, understand what causes them, what they look like,
Right.
and how doctors approach diagnosis and treatment. We'll pull up the key takeaways so you walk away feeling, genuinely informed.
Exactly. We've worked to simplify some complex stuff here from these clinical sources. We want to make the connections clear, give you the whole picture without it being overwhelming. Okay, let's unpack this. Let's start right at the beginning, the very start of life. Respiratory challenges in newborns. First up, Neonatal Respiratory Distress Syndrome, NRDS.
Right, NRDS. This is mainly a problem for preterm infants.
Yeah.
The core issue, they don't produce enough surfactant.
Surfactant? Okay, what exactly is that?
Think of it like a detergent, a foamy substance coating the inside of the tiny air sacs in the lungs, the alveoli. It reduces surface tension.
Oh, okay.
So it stops them from collapsing when the baby breathes out, makes it easier to inflate them again. Production really ramps up between 24 and 28 weeks, and it's usually sufficient by 35 weeks.
So if a baby's born too early.
Exactly. Without enough surfactant, those tiny alveoli just collapse.
Yeah.
Widespread lung collapse. It's serious.
So what does that actually look like? If a doctor sees a baby struggling like this, what are the signs?
Well, it's often pretty clear and usually happens right at birth or very shortly after. You'll see really fast breathing, tachypnea, like over 60 breaths a minute. Fast heart rate too, tachycardia. And labored breathing, you might see the chest wall pulling in. Those are called retractions.
Okay.
They might make a grunting sound when they exhale, flare their nostrils, trying to get more air. And cyanosis, that bluish skin tint, means they're not getting enough oxygen. Diagnosis really hinges on a chest x-ray. It typically shows this diffuse, hazy, ground glass look in both lungs because the air sacs are collapsed.
Right.
You also see air in the larger airways standing out, maybe a flat diaphragm from the effort. Blood gases confirm low oxygen, often oxygen that doesn't improve much even if you give them extra.
It sounds like a real fight for every breath. Are there specific things that increase the risk for NRDS?
Yes, there are. Being Caucasian, male, or part of a multiple birth are risk factors. Also maternal diabetes, C-section delivery, and infections around the time of birth. Management-wise, if the baby has a strong drive to breathe, sometimes non-invasive support like CPAP through the nose is enough.
Okay.
But if they're apneic not breathing, or their breathing effort is poor and heart rate's low, they need immediate help. Usually bag mask ventilation, maybe intubation if they don't respond.
And the surfactant.
Oh, absolutely crucial. Giving surfactant directly into the lungs is key if they don't respond well to non-invasive support. It dramatically improves things.
That's good news.
It is. With treatment, survival's around 90%, and lung function often gets back to normal within a month. But it's still the most common single cause of death in the first month.
Really underscores the importance of prevention.
Definitely. That's why giving antenatal steroids to mothers at high risk of preterm delivery before 34 weeks is so important. Helps mature the baby's lungs faster.
It's incredible how vital those first breaths are. Now, you mentioned confusion sometimes. There's another condition in newborns, meconium aspiration. How's that different?
Great point. Meconium aspiration syndrome, MAS. This happens when the baby inhales amniotic fluid that contains meconium, the baby's first stool.
Yeah.
That irritates the lungs, causes inflammation, blocks airways, leads to distress, low oxygen acidosis. The key difference, MAS is more common in post-term babies, or those small for their age. NRDS is about prematurity. MAS is often linked to stress during delivery.
So different cause, different timing. How would doctors spot MAS?
Similar signs of distress after birth, the cyanosis, rapid breathing using extra muscles, grunting, nasal flaring. But the big clue is seeing meconium staining.
On the baby.
Yeah, on the skin, the umbilical cord, or even suctioning it from the trachea. The chest x-ray looks different too, coarse, patchy infiltrates, often hyperinflation because air gets trapped, sometimes even a collapsed lung, a pneumothorax. Management depends on severity. Mild cases might just need oxygen, maybe CPAP. Severe cases often need intubation, mechanical ventilation, and antibiotics are usually given because meconium can cause infection.
And prevention.
Key here is avoiding post-term delivery, maybe inducing labor around 41 weeks, and trying to prevent fetal distress and hypoxia during labor itself.
Okay, so we've seen these early life challenges. Let's shift gears a bit. To understand these conditions better, maybe we need a quick primer on how lungs actually work, the basic mechanics.
Perfect transition. Yeah, thinking about lung volumes helps. It's like gauges. You have tidal volume, just your normal quiet breaths in and out.
Got it.
Then inspiratory reserve volume, that big extra gulp of air you can take in after a normal breath.
Right, like before you hold your breath.
Exactly. And expiratory reserve volume is the opposite, the extra air you can force out after a normal exhale.
Correct.
Put those reserves plus tidal volume together, and the total you can exhale after a max inhale. That's your vital capacity.
Makes sense.
But even after you force everything out, some air stays behind that's residual volume. Super important, keeps the tiny air sacs, the alveoli, from totally collapsing.
Ah, okay. Like a safety buffer.
Kind of, and total lung capacity is just everything, vital capacity plus residual volume. Then there's functional residual capacity, or FRC. That's the air left after a normal, quiet exhale. It's where most gas exchange happens.
And does FRC change with diseases?
It does. Often decreased in restrictive diseases where lungs are stiff and increased in obstructive diseases where air gets trapped, like with hyperinflation. We also measure FEV1, how much air you force out in the first second, and FEC, the total forced exhale.
So volumes tell part of the story. What about the sounds? You called it the music of the lungs earlier. What abnormal sounds might a doctor hear?
Right, listening is key. Wheezing, that high-pitched whistle, usually worse when breathing out, means narrowed airways. Classic in asthma, COPD.
Oh.
Raunchies are lower-pitched, rumbling, almost like scoring. Often caused by secretions in the bigger airways, sometimes clears with a cough. Then crackles, sometimes called rails. These are discontinued, popping sounds, often on inspiration. Think Velcro ripping. It's small airways or alveoli popping open, often due to fluid or inflammation.
Got it.
And stridor. That's a harsh, single-pitch sound, usually loudest over the neck. Indicates a serious blockage high up in the larynx or trachea. Needs urgent attention.
That leads us perfectly into a really major distinction. Obstructive versus restrictive lung disease. This seems fundamental.
It absolutely is. A really key concept. Obstructive disease means the main problem is getting air out. Airways might be narrowed, floppy, plugged. Air gets trapped.
Like trying to empty a balloon with a narrow neck.
Exactly. So on lung function tests, the key finding is a low FEV1-FVC ratio. You can't exhale quickly compared to your total lung capacity. Lungs might be overly compliant, floppy. Examples: asthma, COPD, which includes chronic bronchitis, and emphysema bronchiectasis, cystic fibrosis.
Okay, difficulty getting air out. What about restrictive?
Restrictive is the opposite. Difficulty getting air in. The lungs can't expand fully. They're stiff, restricted.
Like trying to inflate a stiff balloon.
Perfect analogy.
Yeah.
So here, the total lung volumes, total lung capacity, FCC, are all reduced. But because you can often push out the small amount of air you do get in relatively quickly, the FEV1-FVC ratio is often normal or even high. Compliance is decreased, the lungs are stiff.
And examples.
Things like pulmonary fibrosis, sarcoidosis, or conditions outside the lungs that restrict expansion, like severe scoliosis or muscle weakness from something like myasthenia gravis.
That distinction is really helpful. Obstructive out, restrictive in. Now, let's dive into one of the biggest obstructive diseases, COPD, chronic obstructive pulmonary disease. It's a huge issue globally, right?
Massive. And COPD is interesting because it's really an umbrella term. It covers progressive, mostly irreversible airflow obstruction. It happens because of both loss of lung elasticity and increased airway resistance.
And it includes two main conditions.
That's right, emphysema and chronic bronchitis. When we talk about them separately, most patients actually have features of both, though one might dominate.
So what puts someone at risk for developing COPD?
Number one, overwhelmingly, is cigarette smoking. Accounts for maybe 90% of cases.
But not all smokers get it.
Correct. Only about 10–15% of smokers develop clinical COPD, so there are definitely other factors, genetics probably playing a role.
Like that alpha-1 thing.
Exactly. Alpha-1 antitrypsin deficiency. It's genetic. You suspect it in younger patients, say under 45, non-smokers who develop emphysema, especially if they also have liver issues. But that's only 1–2% of COPD. Other risks include occupational dusts, chemical exposures, air pollution, and maybe recurrent childhood lung infections.
So whether it's smoke or something else causing irritation, how does that lead to the actual lung damage in COPD? What's happening underneath?
Good question. It starts with that chronic exposure to irritants. This triggers inflammation in the lungs. Lots of inflammatory cells rush in.
The body trying to protect itself.
Initially, yes.
Yeah.
But these cells release enzymes like elastase that can damage lung tissue, Normally, we have protective enzymes, like alpha-1 antitrypsin, that keep these damaging enzymes in check.
Ah, balance.
Right. But with chronic irritation, that balance is thrown off. You get less of the protective stuff and more of the damaging proteinases. These enzymes start breaking down the lung structure, especially elastin in the end, the stuff that makes lungs stretchy and helps them snap back.
So they lose their recoil.
Precisely.
Mhm.
And the small airways also get inflamed, scarred, and tend to collapse, especially when you try to breathe out. So exhaling, which should be passive, becomes hard work. Air gets trapped behind those collapsing airways. That's the obstruction and hyperinflation.
Wow. The body's response kind of backfires. Okay, let's look closer at emphysema first.
Okay, emphysema. The defining feature here is destruction of the alveoli, the tiny air sacs. The walls break down, creating larger, inefficient air spaces. It's like millions of tiny balloons merging into a few big, floppy bags.
Less surface area for gas exchange then.
Exactly. There are different patterns. Centrilobar is most common, linked to smoking, affects the upper lung zones. Panissonar involves the whole unit, linked to alpha-1 deficiency. Paraseptal is near the edges, can cause spontaneous lung collapse.
What does emphysema feel like for the patient? What does the doctor see?
The main thing, the hallmark, is shortness of breath, dyspnea. It starts subtle, usually with exertion, that gets progressively worse. Cough is often mild, maybe some sputum, but not always.
And on exam?
Prolonged expiration, they take a long time to breathe out. Signs of hyperinflation, that barrel chest shape, increased front-to-back diameter. Lungs might sound quiet when listening, decreased breath sounds because air isn't moving well. They might use pursed lip breathing, kind of blowing out slowly against pursed lips.
Why do they do that?
It helps keep the airways open a bit longer during exhalation, prevents collapse. Patients often look thin, cachectic, partly due to the increased work of breathing. But they're often not cyanotic, not blue, hence the term pink puffers.
Interesting. How's it diagnosed definitively?
Chest x-ray can suggest hyperinflation, flat diaphragms, maybe bullae, those large air sacs. CT scan is more sensitive, shows the destruction clearly.
But the gold standard.
Pulmonary function tests, PFTs, spirometry, shows that obstructive pattern air trapping, increased residual volume, increased total lung capacity. But here's the key differentiator for emphysema.
Okay.
Decreased DLCO, that's the diffusing capacity.
Yeah.
It measures how well gas transfers from the lungs into the blood.
Yeah.
In emphysema, because the alveolar walls are destroyed, that transfer is impaired. DLCO is low.
Got it. Structure is damaged, so function suffers. Now, the other side of the COPD coin, chronic bronchitis. How is that different? And why the blue bloater nickname?
Chronic bronchitis is actually defined clinically. It's having a productive cough, coughing up sputum for at least 3 months a year for 2 years in a row.
Ah, so it's based on symptoms.
Right. Pathophysiology-wise, it's about inflammation in the airways, the bronchi. This leads to the mucus glands getting bigger, goblet cells producing more mucus, and the cilia, tiny hairs that clear mucus, not working well.
So, lots of mucus and trouble clearing it.
Exactly, which makes them prone to infections. The blue bloater name comes from the typical appearance. They're often cyanotic, blue-tinged because of chronic low oxygen, and they often tend to be overweight or obese, possibly bloated from associated heart failure.
What are the main symptoms and exam findings then?
The cardinal symptoms are that chronic cough, often the earliest sign, sputum production, and shortness of breath, especially with activity. On exam, you hear noisy lungs.
Unlike the quiet chest and emphysema.
Right, you hear crackles, coarse rhonchi, wheezing. These sounds might even shift around if they cough and move mucus. And you might see signs of cor pulmonale, right-sided heart failure from the lung disease, things like swollen neck veins, enlarged liver, peripheral edema, ankle swelling.
How do doctors diagnose chronic bronchitis and tell it apart from emphysema?
PFTs again show obstruction. But remember the DLCO difference. In chronic bronchitis, the DLCO is usually normal or close to normal.
Because the gas exchange surface itself isn't destroyed, just the airways are plugged?
You got it. The basic machinery is okay, just clogged up. Chest x-ray might show increased lung markings, maybe signs of pulmonary hypertension like an enlarged heart border on the right side. Labs might show increased red blood cells polycythemia as the body tries to carry more oxygen to compensate for being chronically low. And blood gases often show low oxygen and high CO2 respiratory acidosis.
Okay, that distinction in DLCO seems really critical. Now, managing COPD. Given how progressive it is, what things actually make a difference in slowing it down or improving survival?
Great question. There are really only a few things proven to reduce mortality. Number one, absolutely, is smoking cessation.
The single most important thing.
By far. Quitting slows the rate of lung function decline, reduces exacerbations, lowers mortality risk. It's never too late. We have nicotine replacement, medications like bupropion, varenicline to help.
Okay, stop smoking. What
Yeah.
else?
2, oxygen therapy. But, and this is crucial, it only reduces mortality in patients with severe resting hypoxemia, PO2 below 55, or O2 saturation below 88%, or those with cor pulmonale.
So not for everyone with COPD.
Correct. For those who qualify, it works by reducing the strain on the right heart caused by low oxygen. And the benefit is directly related to how many hours a day they use it. Aim for 15 plus hours.
And number 3.
Vaccinations. Flu shot every year, pneumococcal vaccines, and now COVID-19 vaccines too. Preventing respiratory infections is key to preventing dangerous exacerbations.
So those 3, quitting smoking, oxygen if needed, vaccines impact survival. What about just helping people breathe better day to day, quality of life?
Right. Symptom control is vital. That's where bronchodilators come in. They don't stop the disease progression, but they open the airways, reduce breathlessness, improve exercise tolerance.
What kinds?
We use short-acting ones, SABAs like albuterol or SAMAs like epitropium, often combined, for quick relief or before activity. For daily maintenance, long-acting bronchodilators are the mainstay.
Like LABAs and LAMAs.
Exactly. Long-acting beta agonists, LABAs, like salmeterol, and long-acting muscarinic antagonists, LABA, like tiotropium. They provide 12-24 hours of bronchodilation. LAMAs might be slightly better at preventing exacerbations.
How do doctors choose which ones?
We follow guidelines, like the Goldie criteria, based on symptom severity and exacerbation risk. Many patients end up on dual therapy, a LAMA plus a LABA, for better effect.
What about inhaled steroids?
Inhaled corticosteroids, or ICS, like fluticasone or budesonide, are usually added for patients with more severe disease, frequent exacerbations, or sometimes if they have high levels of certain inflammatory cells called eosinophils, often used in triple therapy, LAMA plus LABA plus ICS.
Are there other treatments besides inhalers?
Definitely. Pulmonary rehabilitation is huge. It's a program with exercise training, education, breathing techniques, nutritional advice. Doesn't change lung function much, but significantly improves symptoms, exercise capacity, quality of life.
Then surgery.
For selected patients with severe emphysema, lung volume reduction surgery can remove the worst affected lung tissue, allowing the healthier parts to work better. And lung transplantation is an option for very advanced end-stage disease. Also, for those with genetic alpha-1 deficiency, protein replacement therapy is available.
Okay, that covers ongoing management. But what happens when things suddenly go downhill? Those exacerbations or flare-ups?
Right, COPD exacerbations. These are acute events where the patient's usual symptoms, breathlessness, cough, sputum, worsen significantly over a short period, usually less than 2 weeks. Often triggered by infections, viral or bacterial, or sometimes pollutants or other stresses.
How do they present? What do doctors look for?
Clinically, you'll see worsening wheeze, maybe diminished breath sounds, increased work of breathing, faster heart rate, changes in sputum color or amount. Severe signs include using neck muscles to breathe, difficulty speaking in full sentences, sweating, agitation.
And the workup.
Check oxygen saturation with pulse oximetry, arterial blood gases if it's severe, to check oxygen, CO2, and acid levels. Chest x-ray is important to rule out other causes like pneumonia or heart failure. Basic labs, maybe an ECG, flu swab.
How are these exacerbations treated?
It's a multi-step approach. First, ramp up the short-acting bronchodilators, usually a cephasoma combo, given frequently. Second, systemic glucocorticoids like prednisone orally or methylprednisolone VOI are crucial to reduce inflammation. They shorten recovery time and reduce relapse risk.
What about infections?
If there are signs of bacterial infection like increased sputum purulence along with increased volume or dyspnea, then antibiotics are given. Choice depends on local resistance patterns and patient risk factors. Antivirals like oseltamivir if influenza is confirmed.
And oxygen.
Supplemental oxygen is given, but carefully titrated. The goal is usually an O2 saturation of 88–92%. You have to be cautious, especially in patients known to retain CO2, because giving too much oxygen can sometimes reduce their drive to breathe.
What if that's not enough?
If they develop respiratory fatigue or severe acidosis despite these measures, ventilatory support is needed. Non-invasive ventilation, NIV, like BiPAP or CPAP via a mask, is preferred first. It can often prevent the need for intubation. But if NIV fails or isn't appropriate, then invasive mechanical ventilation via an endotracheal tube is required.
What a comprehensive look we've taken today. We started with those fragile first breaths, looking at NRDS and meconium aspiration in newborns.
Yeah, the surfactant story, the post-term risks.
Then we grounded ourselves in the basics. Lung volumes, those different breath sounds like wheezes and
The
crackles.
music of the lungs, yeah.
Then that critical split, obstructive versus restrictive diseases, getting air out versus getting air in.
A really core concept.
And finally, that deep dive into COPD, teasing apart emphysema, the pink puffer, with damaged alveoli and low DLCO, and chronic bronchitis, the blue bloater, with airway inflammation and normal DLCO. Plus, covering the management from those crucial mortality reducers to daily symptom control and handling exacerbations.
It really highlights some fascinating connections, doesn't it? Like how smoking, just one factor, can lead down these related but distinct paths within COPD, or how understanding something specific like DLCO helps pinpoint the type of damage.
Definitely.
And it shows the power of intervention surfactant for babies, smoking cessation and oxygen and rehab for adults. These things make a huge difference. And appreciating the basics, like lung sounds and volumes, gives us the language to understand what's happening.
It really does. This knowledge isn't just abstract, it shines a light on how incredibly delicate yet resilient our breathing is, and how much medical science can do to help when things go wrong.
Absolutely. And maybe a final thought for you to ponder. We talked a lot about managing existing damage, especially in COPD. But thinking ahead with rising pollution and our growing understanding of genetics, what might the future hold for preventing this damage or even reversing it? Could personalized medicine move beyond just symptom control to actually healing the lungs? Something to think about.